So the next speaker is Nikhil Munshi, who will talk about MRD techniques and their impact.
Thank you so much, Hervé and John and Mohammed and Terry for inviting me and Professor Nagler to be here. I think it's a really interesting time to be in France. Just having gone through the nightmare of election in America, I'm hoping the French people would be wiser than the U.S. But back to our topic for the day, I'm going to talk about MRD, which has become an important, more recent endpoint for various aspects in myeloma, and try to cover some of those aspects and why it should and would become a standard of care in very near future. As we know, with the treatment, doublets and triplets, as you heard in the morning, our CR rates have increased significantly, and it's becoming more and more difficult for studies to show differences in our lifetime for the drugs to be approved. So with lots of agents, we need a better endpoint. One of the endpoint has been, can we do better than getting CR? In the meantime, the better techniques are being developed to measure it, and as you will see in a minute, we have made great progress from a very difficult method that could detect very small number of myeloma cells to techniques which can do the same or better, but in a very short time and in a very feasible manner. And then there's a clear evidence over the last 10 to 15 years which drove the more recent development that patients who get MRD negative do better. So there's been track record in the last 12, 15 years that we can achieve this. And if we look at publication, the very first publication was in 1998, which looked at IgH heavy chain and to look for detection of few myeloma cells. And so this has been effort for last 19, 20 years to develop methods to detect very small number of men. And I am using Hervé's one of the slides that depicts so very well that even when we get a CR, there is more than 1 billion cell present, and that we need to detect something which is under the surface of what the currently detectable method is. And as you will see, the depth matters. As we get a deeper CR, deeper response, I wouldn't call it just CR, we get deeper response, we get better outcome. And to that effect, the methods that have developed is helping us go deeper and deeper. As John very elegantly mentioned, if you look at stringent CR by free light chain, or if you look at CR utilizing the older versions of flow, we can do, instead of 1 cell in 100, we can do 1 cell in 10,000 or better. And one of the very first method, which was 1998 method, and till very recently, was the ASO PCR method. And it's some of us who have done it, it's very tedious, difficult method. It takes almost a month to do it on a patient. And it is quantifiable. It can detect 1 in 100,000 cell, but not a practical method to do it. And over time, two methods that have developed are very sensitive, very feasible in our regular practice. And one of the methods, which is reasonably a gold standard so far, has been the multiparametric flow cytometry, where you can use multiple surface antigens and look for cells which can differentiate the clonal plasma cells from the normal plasma cells. And so ability to detect clonal plasma cell is the key in this. And the 8-cuddle flow done most recently using 2 tubes can detect this to a very good sensitivity. And it can detect not only the clonal plasma cell, but if the plasma cells over time has persisted or not in a small amount. Now, this method is also, the second method is also based on uniqueness of the plasma cells. The flow method is based on the uniqueness of the cell surface proteins on the plasma cell. It utilizes what is uniquely different in those cells. The second method utilizes what is unique at a genomic level. Similar principle, just different methods. And so, as you know, when myeloma cells become malignant, it comes from a single plasma cell which has undergone a standard VDJ rearrangement. The immunoglobulin loci on the chromosome 14 for heavy chain is recombined, followed by somatic hypermutation, and the sequence there. So first there is a DJ recombination, followed by VDJ recombination, and this area, which actually forms the main part of the immunoglobulin, is unique to each of the plasma cells unless it is clonally progressing. And so in myeloma cell, there is only one specific VDJ sequence that would be present in each of the patient. And utilizing this, one can then apply methodology to look for any cell with that specific sequence. So there are three assays done in one tube. Using the functional allele which makes the immunoglobulin heavy chain, you could use various primers to look for the specific CDR3 sequence. You can look at a non-functional where it's only DJ, you look for those sequences, and then for the light chain, you look for the light chain sequences. So you have three different sequences to look for. Each one would be one unique sequence for a given myeloma patient. And so the methodology is very simple in this. You take the patient bone marrow, get the genomic DNA, and then do the PCR using multiple sequence. And the most recent method utilizes all the primers in one tube, so you don't have to have 3 tubes and need less number of cells. Bottom line, using this multiplex PCR, you end up with a PCR product which you then amplify, put it into the right cassette, sequence it, and then using the standard algorithm bioinformatic tool, you can identify what is the myeloma specific sequence in this given patient. And then that sequence become our standard to be utilized when we look for MRD sample. So when we get the MRD sample, we take all the bone marrow, 5 million cells, get the genomic DNA, and sequence this area and look for how many cells in that bone marrow contain the same sequence. And that gives you, in a simple term, proportion of plasma cells present. If you don't see, if in 5 million cells you don't see 3 or more sequences or 2 or more sequences, you know it's below the 1 in a million limit. And there's very good statistics done depending upon how many cells you have put into the system. So you can identify the clonotype, you can look for the frequency. And using this method, it's been shown that in the older version, the flow was detecting 10 to the power 4 cells, and then the molecular method would detect 1 cell in 10 to the power 5 or 6. More recently, in the last few years, the flow method has been very well standardized by our colleagues in Spain, and now the method allows us to look for close to 10 to the power minus 5, or sometimes even better than that, for presence of those cells. And that makes both this effort quite applicable in our clinical setting. So if you look at then what we have, the two methods, we use universal reagents. Applicability for flow is much higher. We can do it in close to 100% of the patient. In sequencing, because we may not be able to get the specific sequence in small number of patients, around 7 to 8% of the patient, in 92+% patients, we can do the sequencing-based method. The sensitivity of sequencing-based method is probably uniformly higher than what can one do with flow cytometry. If Bruno Paiva is doing it, you might get excellent sensitivity, but if somebody who hasn't been as closely involved in the methodology, might be a little bit more difficult. But still, it can detect 1 cell in 10 to the minus 5 quite routinely using 8 antigen 2 tube method. The flow method doesn't look at evolution of the disease. The surface is looked at very similarly. On the other hand, sequencing-based method, I won't have time to show today, but we know that it can evolve over time and it can detect the evolution. The turnaround time for flow is very quick, 1 to 2 days. It's a flow-based method. The sequencing-based method, we need to first sequence the myeloma-specific sequence, which takes a little bit longer, and then eventually the MRD itself measurement is a quicker process. So using this, multiple studies have shown that the sensitivity, the depth matters. And this study performed by Martinez Lopez from Madrid clearly showed that when patients had 10 to the minus 5, 1 cell in less than 10 to the minus 5 sensitivity, those patients had much better outcome than those who had -3 to -5 and those less than -3, suggesting deeper we can measure better the patient's outcome. And another study done by him was very elegant. He compared both flow-based method versus sequencing-based method, and there was some correlation. Around R square was 0.58, 0.6, but there were patients who were only detected by flow method, but they were not detected by sequencing method. There were 5 patients in that category. And 4 of those 5 patients have still not relapsed. Only 1 patient has relapsed out of this group, and one can follow and see what happens to that. On the other hand, there were a number of patients who had positivity on sequencing but negativity on flow. And if you look at those patients, those who were flow positive and sequencing positive and flow negative, the red curve had an inferior outcome compared to those who were sequencing negative patients. And so suggesting that if you do deeper, which is what sequencing was in this case, you can have a better outcome as far as result is concerned. So bottom line is, we need to look at deeper response. And the most elegant study was a Harvey study done very recently, where in the IFM DFCI patient population, MRD was measured pre-maintenance, post-maintenance, and of course at the diagnosis there was calibration, and also in any patient who got CR. And in this study, if you look at patients who got 10 to minus 6 versus the rest, you can see the curve is here. When you go 5, the curve comes down, and when you do 4, the curve comes down further. When you combine all this, it really shows that if you get 10 to minus 6 sensitivity, those are the patients who do the best. 4 and 5 are in the middle, not good enough and not much differential between them. And then, of course, patients are more than minus 4, they are not doing as well. So clearly, in pre-maintenance setting, this is what you observe. And if you look at the same analysis in patients who were post-maintenance, again, 10 to minus 6 is the top curve, 4 and 5 are bunched in the middle, and less than minus 4 is below, and suggesting that deeper is the better. And 10 to minus 6 appears to be a consensus amongst everybody, is that's a level of depth we need to get more clear positivity or clear understanding of patient status. So that has become an accepted norm in last year or two in all those who work in this field. And if you look at patients who were flow negative in this particular study, patients who are negative flow, but then were positive with 10 to minus 6 sensitivity, had an inferior outcome compared to those who were negative by molecular method. And so, again, even if they were FCM positive, again, in this case, FCM was 10 to minus 4, you can see better outcome when you do minus 6. And same thing applies for post-maintenance setting. So this study clearly demonstrates the superiority of getting 10 to minus 6 level, and more importantly, superiority of getting MRD as a marker for predicting superior PFS. Another study that was very interesting was Rostron study using the UK MRD 9, the 9 study, UK 9 study data, and that showed that for every log improvement in sensitivity, there is 10% improvement in the survival. So you can see the curves coming up with deeper response from minus 3 to 4 to 5 in this particular case. And so, again, all these studies now bring us to a point that 10 to minus 6 is what we need to achieve. The second question is, where does MRD assessment play a role? In what setting do you do MRD assessment? And a number of studies have shown, so this was a study, again, the British study, that showed that post-transplant, 100 days, when you measure MRD, patients who are MRD negative doing superior compared to those who are not MRD negative. So it's clearly when you have given appropriate treatment, post-treatment, those numbers matter. This is one of the studies that was Italian study that Antonio was part of, and that showed that MRD kinetics matters, that if patients achieve MRD negativity and has persistent MRD negativity, they do the best compared to those who do not persist and or not achieve it. And more importantly, patients who get MRD negativity but within a short period of time, within 12 months, become MRD positive, their outcome is almost no different than those who do not get MRD negativity. So getting MRD negativity and having it persist over 12 months period was an important landmark in this study. Again, these are all very small studies because these were done with the older technologies, and that's where the problem is. More recently, with the Pollux and Castor study, Harvard presented data at ASH showing that patients who got 3-drug regimen, even in relapse setting, get higher proportion of MRD negativity, and that's an important point, that you can get MRD negativity even in relapse patient population when you utilize the 3 drugs. So original idea was that MRD should be a newly diagnosed patient, maybe post-transplant, Now it's becoming clear that not only that setting, but even in relapse setting, we can get MRD negativity, and hopefully the outcome in those patients will be different as we follow them for a longer period of time. So there are a number of these smaller studies done, and there's a study which showed that when you get maintenance, patients get increased number of MRD negativity, and that was another way of judging if maintenance works. But these all studies done so far were smaller studies in bulk, and so more recently we had done a meta-analysis. It was large meta-analysis, 304 different publications were reviewed and 21 publications were identified to have unique patients not overlapping with each other, using sensitivity of 10 to minus 4 and using more well-defined criteria with PFS and OS as a follow-up. And so in these 21 studies, there were 1,500 patients who were followed for achieving MRD negativity, and 496 were who had CR and measurement of MRD status. And this study clearly shows that both for overall survival on the right side and PFS on the left side, patients who get MRD negativity do better. So there's a clear separation of the curve on the both sides. It also shows that if you look at these forest plots curves, every study shows that patients getting MRD negativity has a superior outcome. So overall, of course, there's a very significant value here, but every study shows is on the left side, and both for PFS and both for OS. So this clearly suggests that using 1,500 patients data set, MRD negativity has an important outcome there. In patients who achieve CR, that's another thing. That study included everybody to some extent, but patients who achieve CR, 5 studies had clearly shown, 3 of them were larger study. All 5 studies shows benefit of getting MRD negativity for outcome, both PFS and OS on both the sides. So again, that suggests the same thing. And then if you look at what is the improvement in patients with CR for PFS, you could see that MRD negative in this one was 56 versus 34 months, and if you follow for 5 years, 48 versus 27 months. So even in CR patient, we can identify patients who are MRD negative. Same applies for overall survival, 112 months versus 82 months. Again, all CR patients MRD negative or positive, and this is 3, 5, and 7-year differential for the same patient population. So again, this large meta-analysis confirmed that MRD will provide better outcome when taken together. So the final question for us is, can MRD inform the treatment? So all this is well and good. We need to measure MRD. We know who's going to do well. Can we decide our treatment based on MRD? And that's a more question for us to go forward to see what we do. And part of the analysis that Harvey has done, which provides really good clue to what we should be thinking about in future. So in the IFM DFCI study, there were 2 arms. One arm got transplant, one arm did not get transplant, just got RVD. And in this study, the top 2 overlapping curves are patients who got MRD negativity, either with transplant or with without transplant, with just RVD. So irrespective of how they got the response, if they got MRD negativity, they do very similarly. I'm not identifying which color is what because they are overlapping curve. As you know, previously what you saw was the patients getting transplant had much better PFS compared to those who did not get transplant. However, if you look at those who got MRD negativity, transplant or no transplant are overlapping curves, suggesting, very importantly, that if we get MRD without transplant, they might do as well as those who get with transplant. And this information is going to translate into therapeutic changes that we may think about in near future. Secondly, the patients who got MRD negative and who are in a different risk category. The top 2 curves here, which do not separate significantly, again, small number of patients, but suggest that even high-risk patients, if they get MRD negativity, they do better or very similar to those who are standard risk. So once this study is expanded, similar patient population is expanded, we will get more clarity. But again, it's to the point that if we do get MRD negativity, the risk may not be as important. And so what do we need to do? We need to move on now. I don't think there's much to discuss about whether we do MRD or not. I think we do MRD, they do better, and we have multiple questions to answer. So do we need maintenance? What is the length of maintenance we need with MRD negativity? Should all patients become MRD negative? So if they don't get it after transplant and maintenance and consolidation, do we need second transplant? Do we do CAR-T or something else? Question would be whether MRD positive patients who are MRD positive, should they be treated as a relapse patient or refractory patient and be treated that way? And then thus critical question is, does early detection of clone which had disappeared by our testing means he is relapsing, and do we act then? Would we wait, or what do we do? So we have a number of clinical questions to answer now, and there are studies being planned. One problem for MRD measurement the way we do today is that it is done with one bone marrow in one spot in the body. We don't check the whole body. We saw earlier that there could be various clones elsewhere, and so we have to keep that in mind. And the talk after me, Elena, would be talking about whether presence of tumors elsewhere can be selected and detected by imaging technology, and that can be incorporated or not. So that would be the segue for my passing on to her. Two technologies under development that may answer also by laboratory method is to look for circulating DNA and to look for circulating myeloma cells. We can do single cell isolation from circulation and look for it, and we can do circulating DNA quite reliably at a certain depth. And these technologies are in development. We do it now in our research setting quite routinely. They need to be validated in the appropriate setting. So finally, there is some standard developed for MRD negativity published recently by Shaji and a lot of people in this room, that it can be standard of our measurement of response. We have to optimize the MRD assessment for sensitivity, accessibility, feasibility, and the cost for doing the test. But 10 to minus 6 is the standard. NGS may be applicable in all. MFC can be utilized in those who failed the NGS method because we couldn't get the primary clone detection. And MRD should and would be the standard of measurement of objective response in the clinical trial, and probably to find who are the cured patients in future. Thank you very much.